Anemias. Textbooks. Guyton and Hall. Textbook of Medical Physiology. 11th edition. Pages 423, 426 to 427. Anemia means deficiency of hemoglobin in the blood, which can be caused by either too few red blood cells or too little hemoglobin in the cells. Some types of anemia and their physiologic causes are the following. Blood loss anemia. After rapid hemorrhage, the body replaces the fluid portion of the plasma in 1 to 3 days, but this leaves a low concentration of red blood cells. If a second hemorrhage does not occur, the red blood cell concentration usually returns to normal within 3 to 6 weeks. In chronic blood loss, a person frequently cannot absorb enough iron from the intestines to form hemoglobin as rapidly as it is lost. Red cells are then produced that are much smaller than normal and have too little hemoglobin inside them, giving rise to microcytic, hypochromic anemia, which is shown in figure. A blood smear of a patient with blood loss anemia. Aplastic anemia. Bone marrow aplasia means lack of functioning bone marrow. For instance, a person exposed to gamma-ray radiation from a nuclear bomb blast can sustain complete destruction of bone marrow, followed in a few weeks by lethal anemia. Likewise, excessive X-ray treatment, certain industrial chemicals, and even drugs to which the person might be sensitive can cause the same effect. Megaloblastic anemia. Based on the earlier discussions of vitamin B12, folic acid, an intrinsic factor from the stomach mucosa, one can readily understand that loss of any one of these can lead to slow reproduction of erythroblasts in the bone marrow. As a result, the red cells grow too large, with odd shapes, and are called megaloblasts. Thus, atrophy of the stomach mucosa, as occurs in pernicious anemia, or loss of the entire stomach after surgical total gastrectomy, can lead to megaloblastic anemia. Also, patients who have intestinal sprue, in which folic acid, vitamin B12, and other vitamin B compounds are poorly absorbed, often develop megaloblastic anemia. Because in these states the erythroblasts cannot proliferate rapidly enough to form normal numbers of red blood cells, those red cells that are formed are mostly oversized, have bizarre shapes, and have fragile membranes. These cells rupture easily, leaving the person in dire need of an adequate number of red cells. A blood smear of a patient with megaloblastic anemia. Maturation failure caused by poor absorption of vitamin B12 from the gastrointestinal tract, pernicious anemia. A common cause of red blood cell maturation failure is failure to absorb vitamin B12 from the gastrointestinal tract. This often occurs in the disease pernicious anemia, in which the basic abnormality is an atrophic gastric mucosa that fails to produce normal gastric secretions. The parietal cells of the gastric glands secrete a glycoprotein called intrinsic factor, which combines with vitamin B12 in food and makes the B12 available for absorption by the gut. It does this in the following way. 1. Intrinsic factor binds tightly with the vitamin B12. In this bound state, the B12 is protected from digestion by the gastrointestinal secretions. 2. Still in the bound state, intrinsic factor binds to specific receptor sites on the brush border membranes of the mucosal cells in the ileum. 3. Then, vitamin B12 is transported into the blood during the next few hours by the process of pinocytosis, carrying intrinsic factor and the vitamin together through the membrane. Lack of intrinsic factor, therefore, causes diminished availability of vitamin B12 because of faulty absorption of the vitamin. Once vitamin B12 has been absorbed from the gastrointestinal tract, it is stored in large quantities in the liver, then released slowly as needed by the bone marrow. The minimum amount of vitamin B12 required each day to maintain normal red cell maturation is only 1 to 3 micrograms, and the normal storage in the liver and other body tissues is about 1,000 times this amount. Therefore 3 to 4 years of defective B12 absorption are usually required to cause maturation failure anemia. Failure of maturation caused by deficiency of folic acid, pteroyl glutamic acid. Folic acid is a normal constituent of green vegetables, some fruits, and meats, especially liver. However, it is easily destroyed during cooking. Also, people with gastrointestinal absorption abnormalities, such as the frequently occurring small intestinal disease called sprue, often have serious difficulty absorbing both folic acid and vitamin B12. Therefore, in many instances of maturation failure, the cause is deficiency of intestinal absorption of both folic acid and vitamin B12. Hemolytic anemia. Hemolytic anemia or hemolytic anemia is a form of anemia due to hemolysis, the abnormal breakdown of red blood cells, RBCs, either in the blood vessels, intravascular hemolysis, or elsewhere in the human body, extravascular. This most commonly occurs within the spleen, but also can occur in the reticuloendothelial system or mechanically, prosthetic valve damage. Hemolytic anemia accounts for 5% of all existing anemias. It has numerous possible consequences, ranging from general symptoms to life-threatening systemic effects. The general classification of hemolytic anemia is either intrinsic or extrinsic. Treatment depends on the type and cause of the hemolytic anemia.
If you want to read what is said above, stop the slide.
Different abnormalities of the red blood cells, many of which are hereditarily acquired, make the cells fragile, so that they rupture easily as they go through the capillaries, especially through the spleen. Even though the number of red blood cells formed may be normal, or even much greater than normal in some hemolytic diseases, the lifespan of the fragile red cell is so short that the cells are destroyed faster than they can be formed, and serious anemia results. Some of these types of anemia are the following. In hereditary spherocytosis, the red cells are very small and spherical rather than being biconcave discs. These cells cannot withstand compression forces because they do not have the normal loose, bag-like cell membrane structure of the biconcave discs. On passing through the splenic pulp and some other tight vascular beds, they are easily ruptured by even slight compression. Hereditary spherocytosis. In sickle cell anemia, which is present in 0.3 to 1.0% of West African and American blacks, the cells have an abnormal type of hemoglobin called hemoglobin S, containing faulty beta chains in the hemoglobin molecule, as explained earlier in the chapter. When this hemoglobin is exposed to low concentrations of oxygen, it precipitates into long crystals inside the red blood cell. These crystals elongate the cell and give it the appearance of a sickle rather than a biconcave disc. A blood smear of a patient with sickle cell. The crescent-shaped sickle cells can be seen in the smear. The precipitated hemoglobin also damages the cell membrane, so that the cells become highly fragile, leading to serious anemia. Such patients frequently experience a vicious circle of events called a sickle cell disease crisis, in which low oxygen tension in the tissues causes sickling, which leads to ruptured red cells, which causes a further decrease in oxygen tension and still more sickling and red cell destruction. Once the process starts, it progresses rapidly, eventuating in a serious decrease in red blood cells within a few hours and, often, death. In erythroblastosis fetalis, Rh-positive red blood cells in the fetus are attacked by antibodies from an Rh-negative mother. These antibodies make the Rh-positive cells fragile, leading to rapid rupture and causing the child to be born with serious anemia. The extremely rapid formation of new red cells to make up for the destroyed cells in erythroblastosis fetalis causes a large number of early blast forms of red cells to be released from the bone marrow into the blood. Effects of anemia on function of the circulatory system. The viscosity of the blood depends almost entirely on the blood concentration of red blood cells. In severe anemia, the blood viscosity may fall to as low as 1.5 times that of water rather than the normal value of about 3. This decreases the resistance to blood O in the peripheral blood vessels, so that far greater than normal quantities of blood O through the tissues and return to the heart, thereby greatly increasing cardiac output. Moreover, hypoxia resulting from diminished transport of oxygen by the blood causes the peripheral tissue blood vessels to dilate, allowing a further increase in the return of blood to the heart and increasing the cardiac output to a still higher level, sometimes 3 to 4 times normal. Thus, one of the major effects of anemia is greatly increased cardiac output, as well as increased pumping workload on the heart. The increased cardiac output in anemia partially offsets the reduced oxygen carrying effect of the anemia, because even though each unit quantity of blood carries only small quantities of oxygen, the rate of blood O may be increased enough so that almost normal quantities of oxygen are actually delivered to the tissues. However, when a person with anemia begins to exercise, the heart is not capable of pumping much greater quantities of blood than it is already pumping. Consequently, during exercise, which greatly increases tissue demand for oxygen. Extreme tissue hypoxia results, and acute cardiac failure ensues.